Good day, and thank you for the scientific committee for inviting me to give the introduction to this roundtable of discussion about the use and access of COVID treatment in outpatients and inpatient in low and middle income countries. These are my disclosures. So this figure has become the classic scheme of the different clinical stages of SARS-CoV-2 infection. And as you know, in the first stage, the goal is to diminish the viral load and to improve the immunity, and therefore the use of antivirals and monoclonal at this point is recommended. However, in the stage of hyperinflammation, the objective is to reduce the morbid mortality and treat hyperinflammation, hypercoagulation. So more than 20 months of this pandemic, what do we know? Well, what we know is what it has shown no benefit at all, such as hydroxychloroquine, use of ivermectin, azithromycin, protease inhibitors, vitamins, chloride in any presentation. And on the other hand, what do we know that really works? Well, prevention is still the key for fighting this epidemic, such as the use of face masks, social distancing, proper air ventilation, testing and isolation, vaccination. And there's a few therapies tools that we have found to be scientifically benefit, such as two antivirals, steroids, and monoclonal antibodies. But the question is, can we all access to them? There are plenty of guidelines around the world, nationally, regionally, internationally, and still what we see still in 2021, these kind of prescriptions are frequently found in low and middle income countries such as mine in Mexico. And as you can see, there are abuse and misuse of medication, more than 10 medication for one patient, not only for outpatient, but also for hospitalized patients. But why is this? Low and middle income countries face many challenges. There are different guidelines with an heterogeneous approach to evidence-based recommendations, not necessarily updated. There's strong traditional medicine or popular medical remedies to treat COVID-19 and many other diseases. There's limited access to testing and novel therapies, unequal distribution of vaccines, and political issues have impacted public health. And unfortunately, according to the OCDE, there has an important increase of poverty due to the pandemic in the most affected countries, such as, for example, in my region in Latin America. Additionally, medical resources have been concentrated in very few regions, such as in the United States and European countries. And several manufacturers countries have posed restrictions to export medical resources to guarantee their own domestic supplies, which has hindered the access to essential products such as COVID treatment, PPE, and vaccines to fight the pandemic in low and middle income countries. This is a busy slide that has been reported by the Pan American Health Organization. And I remember that in the first semester of 2020, this list was only 46 randomized clinical trial intervention for COVID, and now it has more than 400 interventions. And as you can see, still what we see is that very few are in green, have shown beneficial effect for the outcomes of patients with those interventions. And really, in the other and more are in green, red, and black, which has shown really no benefit. So despite the large number of clinical trials worldwide, only a small proportion are currently being conducted in low and middle income countries, due to many barriers, but many of them are that in those countries are less international collaborations for research, low resources, and a problem for the capacity and expertise to conduct clinical trials. So talking about the specific treatments, dexamethasone and steroids have been proven due to the recovery trial to be effective to reduce mortality in severe COVID infection. And it's not recommended in mild disease and only in those hospitalized in need of high flow oxygen. However, the variation among the prescription in regions like mine and low and middle income countries with an inappropriate timing and use of extra hospitalized non-severe disease has led to harmful consequences, such as the emerging of infections such as mucormycosis and invasive aspergillosis, which has been a health problem, a really important health problem for many countries like India and in Latin America. Talking about remdesivir has proven to reduce the time of symptoms resolution with no increasing risk of adverse event. It's not recommended as an ambulatory treatment. It is only for hospitalized patients, and there are many agreements that allows the manufacturer for distribution in many countries, including in low and middle income countries currently. But what happens with the monoclonal antibodies? It is just specific for a specific population with a SARS-CoV-2 infection. It is for ambulatory patients with mild disease, but with very high risk of developing severe disease. But the problem is that it poses an implementation challenge in low and middle income countries, because currently it's only available due to a clinical trial. It is expensive. It is only for a specific particular patient which needs the access of wide testing. It imposes the challenge of a complicated administration, which requires resources and infrastructure, and therefore it's not approved in most of the low and middle income countries. Inhaled corticosteroids should be has probably an impact to improve the time to symptom resolution and decrease hospitalization. However, although there are few studies, many of them are not placebo-controlled with small samples, but this could be a good example of what it's needed, because it's simple, safe, wide available, and inexpensive. Finally, molnupiravir is the latest antiviral that has been informed by Merck in their press release that the study of three-phase study has shown that in non-hospitalized adult patients with mild to moderate COVID, molnupiravir may reduce the risk of hospitalization and death in approximately 50%. And they have committed to give patent-free for production in low and middle income countries, and also to sell it to lower prices in constrained settings. But what is the reality? The reality of access to treatment is not equal. This is an example that, thanks to my colleagues and friends that helped me to put together, this is the example of Latin America. And as you can see, these are several countries of my region, in which you can see that tocilizumab is widely available, but with some restrictions, only in private sector, in some hospitals. Remdesivir is not available, for example, in Chile and Peru, and in others that it's available, it's only in private sector, some hospitals, due to and only in recent in this year and not in 2020. But what about monoclonals? see monoclonals in which mostly not available in all of the countries, and in which in the ones who are available, it's only due to clinical trials very recently, or only in private sector. And this really is the reality of what we are facing in low and middle income countries regarding access to COVID treatment. And with this slide, I let you for further discussion in the round table. And I thank all these people who helped me to put together my slides. And I thank you very much for your attention.